So this video is the second part of the anesthesia management of the obese patient. We pick up with the patient positioning in the intra-op setting. Using weight-appropriate tables for obese patients will help ensure safe anesthesia and surgery. As with any patient, paying special attention to pressure spots is essential to avoid neural injuries and pressure sores. As far as patient positioning on the OR table goes, both the supine and Trendelenburg position will further decrease an already reduced FRC in an obese patient. So what patient position will allow for the best visualization for intubation while maximizing pre-oxygenation? According to Barash, the head-up position provides the longest safe apnea period during induction of anesthesia. This extra time gain may help preclude hypoxemia if intubation is delayed. The stacking of towels or sheets under the shoulders and head can help compensate with the flexion that is seen with the cervical fat stores in obese patients. The goal of stacking is for the tip of the chin to be at a higher level than that of the chest to facilitate DL and intubation. The head-elevated laryngoscopy position, also called HELP, goes beyond that of stacking. It elevates the patient's head, upper body, and shoulders above the chest, lining up the sternal notch with the auditory meatus, making direct visualization of the glottis easier for intubation. The use of regional anesthesia can help avoid potentially difficult intubations and the prevention of DVTs, but it is not without its own set of obstacles, such as obscured bony landmarks from redundant tissue. It is important to remember that obese patients usually require 20 to 25% less local anesthetics due to the decreased epidural space from vascular engorgement, fatty deposits, and increased abdominal pressure. If a difficult airway is suspected, having a backup plan such as a glidoscope or bougie catheter is a necessity. Or, if both a difficult mass ventilation and intubation is anticipated, consider using an awake fiber optic approach to intubation where the patient can maintain their own airway during the intubation. Always ensure that an appropriate BP cuff is used, as forearm BP measurements with standard cuff overestimate both systolic and diastolic pressures. Because of the reduced FRC and increased oxygen demands in obese patients, the amount of allowable time spent on intubation is dramatically decreased due to their low O2 reservoir supply. Barash references that 4 vital capacity breaths of 100% O2 over 30 seconds is superior to the 3 to 5 minutes of denitrogenation of 100% O2. In a 2013 review article on the airway management in obese patients, the authors report that the use of CPAP to maintain PEEP at 10 centimeters of water during induction may prolong non-hypoxic apnea by 50% in morbidly obese patients. If the obese patient has uncontrolled GERD or the anesthesia provider is just concerned that the patient is at risk for aspiration for all the reasons we've already discussed, the administration of H2 receptor antagonists, non-particulate antacids like Bacitra, or proton pump inhibitors prior to a rapid sequence intubation should be given. Both the medications and RSI will help reduce the chances of aspiration pneumonitis during intubation. Because of the extra weight in the thorax region, the obese patient must often give extra energy and effort to breathe. In the presence of a neuromuscular blockade, that extra effort now becomes tenfold. So if muscle relaxants have been used, the patient must be reversed and fully awake when ready to extubate. Extubation in the semi-recumbent position has less of an effect on respirations than supine in obese patients, and supplemental oxygen should always be given after extubation. Addressing pain without depressing respiratory efforts is the goal when managing obese patients postoperatively. Modalities such as NSAIDs, acetaminophen, and the placement of local anesthetics into wounds help reduce post-op narcotic needs in the patient. Not only does the use of CPAP or BiPAP reduce the incidence of post-op atelectasis after general anesthesia, it can also help address the risk of hypoxia that occurs in obese patients several days after surgery. So, in conclusion, The anesthesia management of the obese patient has a few unique challenges which we've clearly discussed in this presentation. However, by understanding how obesity physiologically affects the body and the anesthetics used today, the management of this patient population should not be too daunting. And that's it. I hope you got something out of this presentation. Thank you for your time, and good night.